Hello. Well, welcome, everybody. Can I see a thumbs up if my sound is coming through?
We can hear you.
Yeah. Okay, wonderful. I want to welcome everybody from all places. I am pretty sure we have people from just about all over the world. And this is a very nice moment of gathering, a virtual gathering. And we're trying to break through this pandemic and making the most out of it. And thank God for technology. And I really want all of you just to sit back, relax, and have a good time. Let me start by sharing my screen. I want to thank Mr. Hazy for the invitation to make this possible for us to be here today. And I want to bring you greetings from my home in Curitiba. And I am joined by my friend, Professor Andre Ritter, who is in New York.
Thank you, Newton. I appreciate the opportunity to join you for this session today. Likewise, I look forward to having the participation of everybody. It's wonderful to be able to stay connected somehow. I think we're all practicing social and physical distancing in different ways, but the ability to be connected through the internet, through these types of sessions is just incredible. I was just reflecting upon this the other day. We probably would not be together with this many people from all over the world if we didn't have this opportunity. So I look forward to sharing with everybody a little bit about our book, and I'll let you take it from there, Newton.
Thank you, Andre. I just want to make clear that those of you who are listening to this and you want to switch to Portuguese, we have Fabio doing the interpretation, the translation. So there is a button that you can click and switch to Portuguese, so you can hear the translation in Portuguese if you are, if you prefer to do it in Portuguese. Okay. All right, so we're here to talk about our book. And the title of our book is Composite Resin Veneers, the Direct Indirect Technique. I want to make this a very casual talk. And by that, I mean introducing the concept. Why is it that we are here today? And why is it that this book came into existence? Veneers. Why veneers and why composite veneers? Because composites have been around for ages. And we know that for the most part, a lot of us who try to do conservative treatment, minimally invasive dentistry, and using composites will one way or another end up veneering teeth. It may be just one tooth or multiple teeth. So veneers is part of our day-to-day practice. And we're used to the orthodox way. We're used to the direct way. And we've been doing this forever, right? We can do class 4s, we can do class 3s, we can do it directly in the mouth. So composites have proven to be of service for many, many, many years. On the other end, we have the indirect procedures, indirect porcelain veneers, if you will, which can service us as well, beginning in the early 1980s, and it's become a common procedure in this day and age. So these are the two different types of veneering techniques that we are familiar with. But then there is the direct indirect procedure. So let us start by asking ourselves, what is it? What does it mean? What's direct indirect? Where did it come from? So the direct indirect veneers really are veneers in which you will take your composite resin and you will apply it on the tooth without prior etching and adhesive application. And then you will light cure it, remove it, finish, polish. As we will see, we will heat temper our restoration and then bond it, indirectly bond it. Hence the name direct, indirect. It is directly sculpted, just like a direct restoration. However, because it is removed, finished, polished, it can be indirectly adhered to the tooth substrate or bonded, if you will. So what are the benefits of this technique? And where does it come into place? So it's right there in between a direct procedure and an indirect procedure. And it congregates the benefits of both a direct composite restoration and it congregates the benefits of a porcelain veneer restoration. And that's what we attempt to show you today. The concept really started in the mid-1980s with inlays, with posterior inlays, in which the inlays would be built directly in the tooth without being bonded, and it would be light cured and removed, finished, and bonded on the same appointment. But I personally came across the technique for anterior use in the early 1990s when I started reading the articles by Nathan Birnbaum. And in these two articles, Nathan started to show us the benefits of doing these restorations, even single shadedly, monochromatically, and doing them, light curing them, and then heat tempering them to enhance the mechanical, the optical properties, and then bonding them indirectly. So that caught my eye, that caught my attention, and I started to read more about it. And sure enough, I started to gather enough information and clinical experience because I started to see the benefits of such technique, so much so that in 1996, I published an article entitled The Direct Indirect Composite Resin Veneers of Case Report in PPAD. In that article, I took the technique maybe to a higher level because I started to look at the possibility of working on discolored teeth, and then that would require the use of opacers, of Denton shades, in addition to enamel shades, which made the technique a little more elaborate. So the benefits of the technique started to expand. So I started to see that I could not only do a single peg lateral without changing the shade of the teeth, but I could also change the shade and the shape of a tooth that is discolored, that was discolored. Long story short, after 25 plus years, I decided to get together and assemble all the expertise that I had been collecting over the years into a book. At the time, that this was last year, I decided that I wanted to turn that into a book and present my clinical experience along with my teaching experience, because I started to see throughout the years that a lot of peers, a lot of colleagues were benefiting from learning the technique with great success. So I said, why not then put this into a book and share it with the world, with our peers? So sure enough, my wife and I, Grace, whom you see on the screen, we decided to move to Chicago. This was May of last year. And we settled on Lakeshore Drive. And we just lived there for 88 days. So during 80 days, I sat there where you see me staring at the infinite horizon. And from 8 a.m. to 6 p.m., that was all that I did day in and day out. So I started to collect all my thoughts, all the teachings, all the lectures, everything that I had on the matter. And I said, let's get this going. So sure enough, I know Andre having invited me to be an adjunct professor at the University of North Carolina, we went over to Myrtle Beach, and at one point we decided to sit down and get together and talk about it. So I had done my program. We did a hands-on program, a lecture as part of their continuing education continuum. So one day we sat down and I said, Andre, I'd like for you to be part of this project. Knowing his relevance in the world of clinical and research dentistry and all that he had contributed to dentistry, I said, Andre, you're the right person to join me and make this a much better work than I could do on my own. And I was so happy to realize that he accepted and he decided to, make that also his baby. So right from that day on, we started to exchange information, and the rest is history. The rest is what you see here. It's this beautiful book that was assembled into 284 pages in the English version, and that was divided in 6 distinct chapters. And what I want to do now is I want to walk you through these 6 chapters, giving you an overview of what the concept entails. Obviously, we don't have all the time in the world to go into much detail, but I want to at least touch on that which I think it's important in order for everybody to understand the concept and see the restorative possibilities we currently have with the concept. Okay, so I want to just say one thing here before I move forward. If you have any questions, Andre will be moderating the presentation. So if you have any questions, feel free to drop your questions in the question and answer box. Just drop your questions there. And if the question is pertinent at the moment that I am speaking, Andre will reply immediately. If not, we will have a Q&A session at the end. So the direct-indirect concept, what is it? Composite resins and layering strategies. What sort of materials should we use for this technique? And what kind of layering strategies do we have available? We will talk about prepless contact lenses and veneers, and I will point out that there is a difference between a contact lens and a veneer, and what does that entail in terms of material selection and layering strategies. Then the veneer on the discolor tooth, primarily the single maxillary central incisor or a lateral that stands out. What are the concepts that we need to go by? What's the criteria for material selection, preparation, design, and how the concept, how the direct indirect technique will help us with this approach. Chapter 5 addresses indirect restorations fabricated on flexible silicone models. This is when you have multiple units and you don't have the time or you can't perform them in the mouth on one appointment. Then you have to sort of put on your lab technician hat and work from there. And finally, the direct, indirect +5 inlays. Now, this is the technique that I find most thrilling, perhaps, of all the techniques in the book, and I'll share with you why. So let's start with the concept. We all know the orthodox approach. Composites provide us with the ability to do our layering. We can do single shades, we can do 2 shades, bilaminar techniques, we can use multiple shades. The fact of the matter here is composites allow us to be the artists behind our work, and we can congregate the biological challenges that we are faced day in and day out with our ability to recreate the natural dentition in terms of anatomy, in terms of the color nuances that a natural tooth will have. So that all lies in our hands, in the hands of the operator. And that's one of the beauties of working with composite resins. On the other end, we have the ceramic veneers. And just very briefly, my criteria for indicating porcelain veneers will include, among other issues, having multiple units, 6, 8, 10 units, and in which it becomes very hard and stressful to work with composites directly in the mouth. When cost is not a factor to our patients, because it is a factor, and cost may become even more a factor depending on how aggressive or how extensive the treatment is. If the patient has smoking habits that will stain composites over time, we know that ceramics will be impervious to that and will behave a lot better. So maybe that is an indication for ceramics. The dietary habits, beverages, and foods that might stain the composite over time, and the desire for longevity. Now, let me point out that longevity is very relative here, because all materials, all restorative techniques eventually will fail. It's just a matter of how long it'll be before one such restoration will fail, and what is the failure mode. Composite may fail because they chip, because they break, because they discolor. Ceramics may fracture or chip, or they may expose the margins from tissue receding. So, you know, it's just a matter of determining. We know that the lifespan of a composite restoration in the literature we'll find anywhere between 4 to 8 years, but that's an understatement. I'd say that if properly performed, we can expect anywhere between 10 to 15 years easily with good results. So what are the direct and indirect veneers? What are they? They are directly sculpted and indirectly bonded. Remember that? So the question here is, why should we even bother to do these? Number one, marginal adaptation. As you will see, these restorations, they are applied on the tooth without adhesion, and they get an imprint of the margins from the way that you work with the increment. You can literally press the increment with your thumb or your index finger and get an imprint of the margins. Then you can remove this restoration and do the finish and the polish extraorally with aluminum oxide discs, which will give you a knife edge margin and the best finish and the best polish ever, which will consequently incur in superior periodontal health. Because we can do supplemental light activation and heat tempering, the mechanical and optical properties are enhanced. And we have the ability to do a shade track-in very much like we can with our ceramic veneers. So if there's anything wrong with the shade, any minor alteration that is necessary, you can do that via the use of your luting resin, especially if you're dealing with a contact lens on a single tooth and you're trying to match the value and the chroma of the final veneer or contact lens, as we will see. And it can be done in one appointment. So these benefits, when assembled all together, provide me with an advantage over the direct procedure that is unsurpassed. And I will tell you that out of 100 veneers that I do today, easily 90+% are direct and indirect. So what is the criteria for determining whether I can do a direct or a direct indirect? Simply put, whatever you can do, whatever challenge you have in which you can apply your composite, like cure it, and remove it without breaking, meaning there is no interlock, you can do a direct indirect procedure. In addition to it all, there is the cost factor. If you consider the cost of a porcelain veneer, there is the lab fee involved. If you're doing 10 veneers, maybe that's one thing that is, it's, you know, diffused among the price, among the fees. But if you're doing one tooth only, and if you're trying to do a veneer on a single tooth, how much will that cost? We did a quick survey here locally in Brazil in which we called 30 different laboratories, asking them how much they would charge for a single porcelain veneer, a contact lens, if you will, on a central to match the other central. And we had a wide range. The medium was in Brazilian currency, translated into dollars, that would be $250, with the standard deviation that would go from $550 up to $140 thereabouts. Long story short, there is a fee, a lab fee involved. If you want to do two peg laterals, or one central incisor, and you can deduct the lab fee and get results that not only equal, but even sometimes surpass that of ceramics, depending on the ceramist who does it, on the outcome, because it's not always 100% for sure that you're going to get it right on the first time, at least not for me. So you have the ability to deduct that and offer your patients a procedure that will benefit from a money saving standpoint. So again, this is when it all started, you know, with the inlay technique. And then we had Birnbaum looking at the anterior protocol, and then my direct, indirect veneer. And these are all the steps that I was able to gather, looking at what the literature provided, what I was able to gather from my clinical and teaching experience. And these are the 10 steps that anyone would go through when doing a direct, indirect veneer or contact lens. And you're going to go from shade selection to application of the composite, intraoral light curing, restoration removal, extraoral supplemental light curing, heat tempering, extra and intraoral finishing, extraoral polishing, shade try-in, and then the luting. This video shows very simply a contact lens, a thin veneer that I'm demonstrating on a lateral that lacked a little bit of volume. So this is literally what you would do. You can take a single shade, depending on the layering approach, a single shade of enamel, and then literally just thumb it in and press it so that you can get an imprint of the margins. And then you flake it off and you outline the margins with the pencil. And very much like what you do when you're relining a provisional, you finish the margins, you polish, and then you go back in the mouth, you refine the contours, you get the primary anatomy. And then if you need to make any adjustments on your, say, incisal edge position, embrasures, and your facial contour, you can do that. And then you do your heat tempering and supplemental light curing, you do the surface treatment, and then you can do the shade try-in with your shine try-in paste and lute the veneer or the contact lens. So these are the 10 steps that we go through. By the way, when you get the book, there is a QR code that you can use to see a video. It's a longer video, it's a different video than this one, and showing you all the 10 steps, how you would go about doing it clinically, all right? One of the best things, one of the greatest benefits of the technique, it's our ability to get imprints on the subgingival margins. And you can see on this SCM done by Marcus Vargas that we can get a fantastic marginal adaptation. And this is true for veneers when you're working subgingivally. This is true for when you're doing non-cervical carious lesions, the class 5 inlays, as I will show you on chapter 6. And then you can see on the right hand side of the screen, a class 5 that was done, and the SCM that shows just perfect margination, perfect quality of the margins. So this is unsurpassed in terms of the benefits that you get when finishing extraorally, because nowhere clinically can we, with the use of rotary instruments, burrs, and other finishing and polishing instruments, get that kind of marginal finish and polish. So what are the other benefits? You can do supplemental light curing. Remember, a composite will convert from monomer to polymer depending on how well you light activate it, right? It depends on the photoinitiators, the quantity of the photoinitiator, the type of photoinitiator that you have. But for the most part, the more energy you provide, the better your composite will cure. So if we give it enough energy in the mouth when you're doing a restoration in the mouth, there is a chance of you overheating the pulp, which is deleterious to the pulp in a way. The benefits of the direct indirect technique from a light curing standpoint is that you can, outside the mouth, extraorally, give it as much light exposure as you like. For instance, if I'm using a high intensity light like Phthalo, I can set it to 3200 milliwatts per centimeter square and give it 30 seconds, which gives me a lot of energy. And all that I can do in terms of light activation is done extraorally without the heating of the pulp problem that otherwise would arise from doing it intraorally. So all the benefits are there. In addition to that, you can do heat tempering, and heat tempering can be done two ways: with a toaster oven for 10 minutes at 120 centigrades, always dry, or a microwave oven for 3 minutes at 450 watts. Now, the benefits of these techniques is that you get an increased polymer conversion, and we know that that accounts for an increase in fracture toughness. In other words, our restoration is stronger in terms of flexural strength, decreased water absorption, and overall improved color stability. Yes, we know from the literature that composites will undergo a dark phase light cure. Up to 10 minutes, we have a peak, then up to 24 hours, then it goes on till 7 days. But why not have this right from the get-go? Why not have these benefits right from the day one, so that we have a better restoration when we're done bonding it, when we're luting it, okay? Chapter 2, we talk about composite resins and layering its strategies. Now, it's virtually impossible to address all the composite systems available on the market today, because last I checked, there were over 50 different restorative resin systems available on the market, which makes it very hard for one to teach a certain layering technique based on a product brand, because you're locked into a certain brand. So what we do here in the book is we walk you through concepts and criteria for selecting your composites and understanding what are microfills, what are nanofills, what are hybrids, microhybrids, nanohybrids, what are their roles in terms of strength, in terms of polishability, in terms of handling, in terms of compressive strength, in terms of wear. And then we correlate that with the actual restorative systems that we have, okay? But everything that we do with veneers and contact lenses relates to our ability to mimic the polychromicity that we find in the natural dentition. And that, again, needs to be keyed to what we see in the histomorphology of the natural dentition, namely the dent and the enamel and their respective thicknesses at the cervical, middle, and incisal thirds. One of the things that we address in detail in the book is the effect, the optical effect that one will get when selecting enamels of different types of optical properties, of opacities, of refractive index, and what sort of effect you can get. Do we want to get translucency or not? Do we want to get a mamelon effect or not? Remember, we're talking about veneers. Sometimes we have teeth that are very polychromatic, and sometimes we have teeth that are very monochromatic. So selecting your enamel shades according to the thicknesses that they should be implemented, and the thickness of the dentin is very crucial, it's paramount, okay? And then we talk about the different layering approaches. We have the natural layering that uses non-Vita based enamels. This is Didier Dietsch's technique, in which the enamels will be value and chroma modulators of the underlying structure, be it a dentin or an artificial dentin. So these materials can be used for modulating chroma and value. And there is the polychromatic technique that I published on in 1995, which utilizes pretty much all sorts of systems that have enamels that are based on the Vita shade guide and not. So this is maybe a little more encompassing in terms of a technique, because it uses most of the systems available on the market. So a little bit on the polychromatic layering that we mostly teach on in the book is a technique that basically has 5 categories: an enamel, milky white, semi-trans, an enamel trans, an enamel body, an enamel value, and one dentin shade. And when these 5 categories, if utilized all together, are brought together, you create the polychromatic restoration. From a cross-sectional view, this is where they would be used. So you will see throughout the book these terms, the terminology: milky white, semi-trans. It's a non-Vita enamel that we use for our lingual shell to increase the incisal edge position and determine our anterior guidance and incisal edge position. It can be a hybrid, preferably a hybrid, microhybrid, or nanohybrid, or a nanofiller. A dentin, preferably hybrid, microhybrid, or nanohybrids, to provide opacity and chroma from within. And then you have a trans enamel, which can be either microfill, nanofiller, microhybrids, hybrids, nanohybrids, and it's an opalescent enamel that replicates the halos, which you see usually when you have mamelons that are very obvious, such as in the case that you see on the screen. The body enamel is one of the very distinct characteristics of the polychromatic technique, because that is one that provides the hue, chroma, and value to the restoration, and is a Vita-based enamel, preferably used on the cervical and middle thirds. And for this, you can use microfills, nanofillers, nanohybrids, microhybrids, or hybrids as per your preference. And the value enamel, non-Vita-based enamel, usually can be either a nanofiller, a microfill, or a nanohybrid or hybrid, depending on the strength characteristics that you have on the incisal edge. So prepless contact lenses and veneers. What are contact lenses and what are veneers? We differentiate between a contact lens and a veneer in that a contact lens is a very thin veneer that ranges anywhere between 0.2 to 0.5 millimeter, no thicker than 0.5 millimeter. It is used primarily to change the shape of teeth, such as an opaque lateral or a tooth that is lingually positioned, although minor color changes are still possible. And veneers are thicker than 0.5 millimeter, being up to 1.2 or 1.5, and they normally will necessitate the use of a dentin shade underneath to provide opacity, and I'll share that with you a little bit. Okay, so contact lenses. The contact lens, in fact, comes from the actual contact lens that we have for our eyes. And what you see through a contact lens, the final color that you see is a combination of the tooth color plus the composite color that is built into the veneer, plus the luting resin that you use. That's the beauty of the technique, because it allows you not only to change the form, but also to change the shade of your final restoration on account of the drying paste and consequently or subsequently the use of your luting resin. So this is a case in which I did a contact lens. And how do I know it's a contact lens? Because it's very thin. And based on an ideal contour, which can be from a waxed up model or a tooth that is prior to preparation, you assess the amount of room that you have with a putty labial matrix, and you determine that you're up to 0.5 millimeter. And that calls for a contact lens. Beyond 0.5 millimeter, you're gonna end up having low value. It's gonna give you a grayish appearance to it, so a dark appearance to it, and lower value. That's why up to half a millimeter, a contact lens will not really have a major effect on the color, so the final color. So beautiful as is, I can just simply bond that thin contact lens, in this case with one single shade of enamel, bringing that central into alignment, changing the shape of the tooth and also the shade to some extent. Now, in the book, we give you distinct classifications for the contact lenses and the veneers. And we address when there is modification of the incisal edge, such as an increase in length. Let's say you may decide not to increase the incisal edge length, but you want to change the labial volume. So that's a very thin contact lens that can be restored or created using three types of approaches. One, using a body enamel, which you see in yellow, or a value enamel or non-vita enamel, or a combination of both. So that depends on each case that you're restoring. This case, for instance, is a case where you have two central mandibular incisors that were discolored and that were lingually positioned, requiring a little bit of a thicker volume on the facial. So what I did here was I simply used a Vita-based enamel, a body enamel, and I was able to bring the two centrals into alignment and also change the shade that I wanted, that I needed. And you can appreciate in the black and white photograph from on the upper right-hand corner and the lower one, the change in value that I was able to do very simply using only one single shade of a body enamel. Sometimes you need to change the position of your incisal edge, maybe teeth that are eroded, maybe teeth that need to be augmented in their incisal edge position, and you want to do a minor increase. So for that particular scenario, you want to use a milky white semi-trans. Usually, when I say milky white, it's not a shade per se, it's just a category. Think of enamel. Enamel usually around the halo has that milky whiteness appearance to it. Hence the name milky white semi-translucent, just a category, and you can choose this from any system available on the market, okay? So this is a case in which I am doing that type of layering. So I'm doing the incisal edge position, augmentation with a milky white, and then a single value enamel shade. I could have used a body enamel or a combination of both. In this particular case, just a non-vita enamel was sufficient to allow me to do this. And let me mark me, I did no preparation. There was no preparation whatsoever. I only rounded off a little bit of the sharp corners. I did my direct indirect approach, and I just bonded. One appointment. What you see here is the immediate post-op. Let me walk you through a case, and this is a very typical case that we'll often come across. A patient who comes from the orthodontist and requests that the peg laterals be restored to proper morphology. We bleach, and now we're ready to do the restoration on the two laterals. Now, because it's very thin, it doesn't mean that the contact lens will not require more than one shade or a polychromatic layering approach, such as in the case that you see on the screen, in which I used 4 different types of shades and products to achieve the variation of opacity, of chroma, of color that I needed. So that is really dependent on what you have at hand and what the challenge calls for. These were very thin contact lens veneers, and you can appreciate the light transmitting through it, and you can see right through it. It's almost glassy-like, all right? Very glassy-like. So what you can do here is try it on and try it in with your luting resins. I'm sorry, not your luting resins, but your trying in paste. And once you decide upon the one that is best suited, you bond it. And in this case particularly, I used just a clear one because I didn't want to change the color in any way. I was just using the substrate color. That's the benefit of the direct indirect approach such as this. Just think of this. If you do this via an indirect way, if you do a porcelain veneer, there's the cost factor, there is the risk of not being good right from from when you get it, needing remakes. And if you do this directly, you can never get this kind of result that you see on the screen in terms of the quality of the margins. Now, consider this as being the immediate post-op. Sure enough, if I had done a direct contact lens or veneer, if you will, my tissue would never be this good, never. I mean, maybe after healing, but never this good right from the get-go, because my margins are either equigingival or supragingival, even without me having to touch a burr or a finishing instrument to the tissue. And then you have a follow-up of the before and after. Again, the benefits of the technique here: no lab fee, done in one appointment, gives me the ability to appraise the shade and the shape prior to bonding, so I can change it. And again, I'm the artist behind the work, and it gives me a lot of pleasure, and the patient walks out of there in one appointment. Now, let me share another case with you. This is a young lady who wanted me to work on her the maxillary right central lateral incisor, and wanted me to make it very much like the other one. In other words, she wanted me just to veneer it. I said aligners would work well for her. She said she didn't want aligners. She declined ortho. So this is a typical case for a veneer, okay? Just to do a little addition to the facial, bringing the lateral into alignment. Now, there are different classifications for the contact lenses. This is one of them. This is a type 3, in which when you add to the incisal edge and you need to conceal the transition from the tooth to the lingual shell, you will need to use a dent and shape. So this is when you start building in your mamelons and a higher opacity material to conceal the transition from the tooth substrate to your lingual shell, which is what we did for her. We did class type 3, contact lens type 3. So here's what we're going to do. We select the shades, very much like what you do for your direct veneer, okay, or contact lens. The incisal enamel for the lingual shell. In this particular case, I chose 2 body enamel shades, one for the cervical, one for the middle third. Then a little bit of dentin for mamelons, bleach shades for white spots, white characterizations, which she presented with, very subtle, and a value enamel, a non-vita enamel all over the incisal middle third. Okay, here comes the first paradigm. The first paradigm, is you need to pack cord and you don't etch. You don't do anything. You don't have to lubricate the tooth if there are no interlocks. If you don't have an old composite, which would require polishing, you do nothing aside from just packing cord and retracting the tissue. And then you start adding your composite. And then this is a paradigm shift. Why? Because you want to bring that composite over the tissue enough so that you can pat on it and get an imprint of the subgingival area, the intraclavicular area, which will give you that that knife edge margin after you finish. And you cure each layer, cervical, middle third, and then you do your characterization, your white spots, very much like what you would do for your direct veneer. And then you finish your final layer. Now, here's another paradigm. This paradigm means that you need to apply the final layer to a thicker increment. Why so? Because you will then, after light curing, flake off that veneer. And if you make it thin, just like you would for a direct veneer, it might break. Believe me, over the 26 years that I've been doing this technique, I've seen many fracture because I was very shy on the amount of material that I applied on my last layer. So you want to make sure that you make it thick. It doesn't matter if it's thick, because you will finish it back anyways. You're going to take your discs, you're going to go around, finishing around the margins, and then you're going to go back in the mouth and do your facial planes or incisal edge position. And you just finish like you would, except that you're going to finish in the mouth and outside the mouth, which is the beauty of it, because you're not touching the tissue, right? So you finish it, and then you can do your shade try-in. In doing the shade try-in, you do what you will. You do the usual thing that you do for your porcelain veneer. You can try it in dry, you can try it in wet, you can try it in with a clear paste, you can try it in with a high opacity resin, and evaluate the value, and even consider incorporating a little bit of higher chroma loading resins through the try-in stage to decide whether you want to emphasize the chroma a little bit. How do we surface treat? How do we treat the intaglio of our veneers? Very much like what we do for our composite inlays or composite posterior restorations. You want to particle air abrade it with aluminum oxide, 27 or 50 micron, either that or cojet, which is a silicate ceramic, 30 micron particles. And the difference between the two is that cojet will allow you to silinate the intaglio. If you have, say, a microfill, which is not really ideal for silination, doing cojet will enhance the bond strength. So here's what you do. You particle air abrade, then you clean it with phosphoric acid, rinse dry, apply the silane, very much like what you would for porcelain veneer, except that you don't use hydrofluoric acid. It's just sand or particle air abrasion. And then you apply your adhesive, fill it up with the luting resin. In this particular case, I'm mixing a little bit of clear with high opacity and high chroma luting resin. And then I can just do my bonding. Now, if you are doing a contact lens on enamel, there's no dent in substrate. You don't have an old composite. All you need is primarily phosphoric acid and the hydrophobic bonding resin. There's no need for a primer, but you must remove the aprismatic enamel. And let's remember that the aprismatic enamel is a 30 micron thin or thick layer that covers the enamel, which is impervious to phosphoric acid. So you need to sandblast that, or just take your burr and get rid of that aprismatic enamel, and then you can do your phosphoric acid etching and the seeding. And this is what you do usually for your porcelain veneer, very much like what you do. You phosphoric acid etch, apply your bonding agent, take your veneer in, and then you spot cure it, and then you clean and you do your final cure. Nothing is different from an indirect procedure here, folks. It's very much like what you do. And this is what you see immediate post-op, and then after rehydration, and then you see a beautiful integration of color. In this case, we're looking at the value, which is right on, and then the polychromicity that we were able to achieve. All this in one single appointment. You may be asking yourself, how long does it take me to do such procedure? This is usually about a 45-minute to an hour from start to finish, which is a good type of work from a time standpoint. Okay, veneers. When do we do veneers and not contact lenses? Let's switch from contact lenses to veneers. Veneers is when you have a veneer or a contact lens that is thicker than 0.5 millimeter. So what you need to do is you, in excess of 0.5 millimeter, you need to add a dentin material underneath your enamel so that the value doesn't drop, so that you don't have a low value and you keep that veneer with the value that you want. And basically what you want to do here is select the shade of your enamel. If you're a body enamel, you're going to say A1 enamel. It's going to be the same shade for the dentin, A1 dentin, because it's very thin. Or if you are using the natural layering concept and you're using a value enamel, then you want to select the dentin maybe of a higher chroma and use a value modifying enamel to modify that. Or you can use a combination of body and value enamels. Okay, and this is a case, a typical case in which I used this, it's a veneer type 2C, and you can see why this was a case that I needed to do a veneer for and not a contact lens, because I had over 1 millimeter of thickness, and that was evaluated upon my making a labial matrix and gauging this with a perio probe, which told me that I had more than 0.5 millimeter. Then I do my dentin application, my enamel application. I can finish, remove, polish, heat temper, and bond it. What's the benefit of it? Better margins, better contours. In this particular case, I had to do some gingivoplasty, which made it a little harder for me to work with if I were to do this without a conventional rubber damming technique. And you can see the beautiful integration of soft tissue and margins on account of the finishing that we had and the nice polychromatic effect that we were able to get. Now, what about veneers with preparations, especially when we're talking about this color teeth? This is a young patient who at the time was 18 years old, presenting with calcific metamorphosis, and the tooth was not prone to bleaching, so we had to either do a crown or a veneer. And because she had a lot of sound tooth structure, I decided to do a veneer. So she had an old class 4 restoration and a very, very sound enamel and dentin substrate. So we bleached her teeth. She went through home bleaching. And after the relapse, we start the working of the veneer. So veneering a discolored tooth will require preparation, and our preparation needs to be anywhere between 1.2 to 1.5 millimeter so that we can apply, in addition to dentin and enamel shades, an opaquer. And for the direct indirect technique, what you need to do in contrast to the direct technique is you always use a dentin shade first, and then you use an opaquer on top of it, and then your enamel layer. So in other words, you have a sandwich, and you have the bun here and the bun here. This is the dentin, this is the enamel, and your pastrami, so to speak, is your opaquer to raise the value and block out the discolored substrate. And this is what we did here for her. So we did a preparation the conventional way. Let's say in this particular case, a 1.2 millimeter preparation. One of the things that you need to be aware of is if you have defective or old composites and you're not replacing them, you must polish them in order to avoid interlocking of your direct indirect veneer, which is what I'm doing here with a rubber point. Everything else is the same, but you will not etch. You will maybe use a water soluble lubricant and then start your layering. You can do your enamel shade, and then you do the dentin shade, and the dentin shade is, covering the entire dentin substrate, creating your mamelons, and you will continuously appraise the remaining thickness that you have with the use of your labial matrix to see if you have enough room for the opaquer and for the enamel. So after you do the dentin application, you do the opaquer, and at the time you are checking against a shade tab, usually a custom shade tab that I make prior to the actual restoration with the shades that I have selected, so that I have a pretty good guideline in terms of what shades I selected and how I layer them in contrast to the actual tooth. Because remember, natural teeth dehydrate, and when they dehydrate, the value goes up. So I can't compare the natural teeth with the actual tooth that I'm restoring. Hence the need for a custom shade tab to check throughout the procedure. So I have my opaquer, and then I check the chroma and the hue, and then I use the enamels, and I can do my enamel application. I can do tinting. We talk about tinting in the book as well. It's part of one chapter. And then my final enamel layer. Remember, final enamel layer, always very thick, very big, so that you can flake the veneer off, and then everything else is the same. You outline the margin, you do your finishing around the margins, and then again, you go back in and you try the veneer in. You check for precision effect, contour, line angle placement. And when you're happy with it, you do your final finish and polish. Now remember, you get to this point prior to bonding. If you're not happy with it, you have one of two things you can do. You can repair the layer that is mismatching, or you can altogether dispose of the veneer and start afresh. Or maybe just spot bond the veneer, send the patient home, and get the patient back in on another appointment. If you do this with a direct approach and something is wrong, you need to remake, and remakes make the patients and ourselves not very happy. So everything else is the same. And then you want to bond that veneer. And this is what it looks like after I bond the primary anatomy. You can refine it in the mouth. You can get your secondary and tertiary anatomies to final contour, and you can appreciate what a nice blend in, a nice color match that we were able to achieve. Now, again, I just want to reiterate the benefit of the direct indirect approach here in this case, particularly because we had a very dark tooth, and if something had not resulted correctly, if I had done this via the direct approach, then I would be stuck with a defective restoration that would need a remake, which was not the case here because I had control over each step and I was happy with the result prior to bonding. This is the outcome. So very quickly, I just outline now the benefit of working on flexible silicone models. So let's say you have a patient who has amelogenesis imperfecta, okay? And teeth are nice, but they need to be bulged out. You need to reestablish the buccal quarter, change the shape, change the shade. And it's 10 teeth, 10 units. Now, if I am doing this directly, it's time consuming, it's stressful to both myself and the patient. Or if I want to do this via a porcelain veneer approach, that would mean at least minor preparation or at least a peripheral chamfer for proper precision to fit and marginal adaptation, in which case it depends on the cost and it depends on the ability of the operator to provide the final result that you're looking for. Everything here is very much like what you would do in treatment planning, an indirect case with porcelain veneers or ceramic veneers, which would mean doing a mock-up, maybe taking an impression of the mock-up, making your putty stents or waxing up to proper contour, and then following the workflow of the indirect composite technique, which now is done based on a flexible silicone model, which you see on the screen in red. And then you check it on your stone model, and then you bond it. So what's the difference between an indirect procedure and a direct procedure here? You are the operator. You're not relying on a laboratory or a lab technician to do the case for you. Even with composites, you are the artist behind the work. Now, you need to take into account the time consumed, your fee per hour, and if it's feasible from a cost effectiveness standpoint, if it's feasible to you and to the patient. In my particular case, my fees that are contemplated here make it feasible for me and the patient, as opposed to doing a porcelain work. And finally, we're coming to a wrap here, the direct, indirect class 5 inlays. We are used to the direct approach. The direct approach provides a lot of challenges for non-carious cervical lesions, and they are access to difficult to reach areas. Let's say you're doing an upper maxillary second molar, and you're trying to reach into the distal and restoring that. It's very difficult to have access to certain areas, and we all know what it feels like to be able to, not to be able to restore second molar with a non-carious cervical lesion. Field control, how do you control the field? Do you use rubber damming, conventional rubber damming? Do you use your clamps? And the handling of the composite, can you sculpture it? Can you contour it properly? Can you give it the right form? Can you handle it nicely? And then after curing, how do you finish the margin? And what kind of margin do you get? Usually we will incur in some discomfort to the patient because you will take your rotary instruments and you're gonna have a soft tissue that is scarred. And so this is not good. We all know, we've all been there. We usually tell our patients, listen, just gonna wait a week, your tissue will heal back, even when you're using rubber damming clamps. So this is bound to happen. And in addition to the chair side time, that is usually very long if you're doing a quad or 2 quads and you have, say, 8 teeth that you're working on. The direct indirect inlay technique is so much simpler and so much easier and more user-friendly because you work outside the mouth. Inside the mouth just for the application, but everything else is done outside the mouth. Let me walk you through this process and how we do it. Usually for a carious lesion, non-carious lesion of about 1.5 to 2 millimeter deep, all you want to use a Vita-based enamel of higher opacity, like a body enamel or an intermediate opacity of a Vita enamel. That's all you want to use. It can be a nanofiller or a microfill, preferably because of the polish, right? And then you place your bevel. You got to bevel it, just the enamel. And then you pack cord to retract the tissue a little bit. And here comes the beauty of it. You take a little bit of the composite, roll that into the form of a ball, and then with your own finger, you go into the area and you just pat on it, and you take it with your finger and you press on it to get an imprint. And then sure enough, you want to take the instruments and refine the contour. These are 2 premolars, but let's just think that you were doing this on a maxillary second molar. How much harder would it be if you were to reach into that area and get a contour with your instrument, if the patient had a difficulty open up the mouth and thick cheeks, and we all know. So what you do, you get the contour, the composite goes over the tissue, you light cure it, and then what do? You flake it off. You flake it off, you outline the margins, and then you finish and you polish. You go sequentially with the discs, just like you do for your veneers and contact lenses. One of the challenges with this technique is the ergonomics is holding the tiny little inlay in your hand and having control of it. But over time, as you reach a comfort zone, you should be able to do this without a problem. Everything else is the same. You do the sandblasting, you may silanate it, apply your bonding agent, and then I can do the surface treatment on the tooth. And in depth, we discuss in the last chapter how to treat sclerotic dentin, whatnot, and what sort of adhesive to use. If you need to use a selective etching with a self-etch 1-step or 2-step bonding agent, or should you use a 3-step etch and rinse bonding agent? It really depends on the type of the dentin that you have. And this is discussed in depth when we introduce the concept in chapter 6. So in this particular case, you see me using the phosphoric acid, doing selective etch, and then you bond the veneer. The beauty of the technique, once you bond it, you don't touch the subgingival margins. You use your disc sequentially just to finish the flashes that are over the bevel, so you can make the transition very nice and flush without having to touch the subgingival area. That's one of the greatest benefits of this technique. And then you go through your conventional polishing steps, and this is the immediate post-op. You look at the quality of the margins, you look at the quality of the tissue, and let me tell you this, I've been doing these inlays for over 11 years now, and one of the best compliments that I can ever get from my patients is, "Doc, I didn't feel a thing. I didn't feel you working on my teeth. I didn't have any sensitivity." And most of the time, I will not anesthetize the patients. And they say, "This is so quick, so easy, and I didn't feel a thing. And look at my tissue. I don't have any discomfort. Way to go, doc." So this is good for us. This is good for the patient. And this is the technique. All right. So this is all that I have to do in terms of presenting my my case to you along with Andre, and now we're ready to take questions. So I'm just going to stop sharing my screen and I'll hand it over to you, Christian.
Newton, I'm going to jump right in. It was an amazing talk. You did a great job. Thank you for sharing all of that with everybody. I have been able to monitor the Q&A box during the talk. There were a number of wonderful questions. I think I answered most of them. That's why I had my head down and was typing as you were speaking. A lot of very positive comments. A couple of questions maybe that you can reiterate just for the entire group. There was one question that was asking, I think Ivan asked that question about clarification relative to shade selection, and whether you mentioned that for dentin chroma, you always select a little bit of higher chroma. I don't know if that was something that you covered. There was a little bit of a question about that. You know, my understanding on that is, obviously, you know, the dentin chroma is usually higher than the enamel. So if you're selecting the shade through the enamel, naturally you're going to tend to favor a little higher chroma if you're just selecting the shade from the middle third of the tooth, for example. But I'll let you elaborate on that a little bit.
No, you're correct. You're absolutely right. And you nailed it right on. You need to remember that when you are selecting the enamels, there are two types of enamels. One is a Vita-based enamel, which has hue, chroma, and value to it. If you're talking about, this is the polychromatic approach. If you're talking about the natural layering approach, Didier Dietsch's approach, the enamels, they will modulate the color of the dentin that is underneath, or whatever substrate is underneath. So whatever substrate color you have underneath will look lighter after the placement of a non-Vita-based enamel. And Andre, you said it very properly. You have to select the dentin shade that is slightly darker, and then the enamel, a non-Vita enamel, will bring it to a lighter shade with a lower chroma.
Yeah, the questions are really excellent, Newton, and some of them are coming through now. So instead of typing the answers, I'm going to just go ahead and bring them to you. I do think
Please
we
do.
have just a few more minutes left. Some questions about using glycerin gel to avoid oxygen inhibition layer interproximally for class 5 resins. And then if you can also discuss whether sandblasting of the dentin for the class 5, I think you mentioned that people have questions about the bonding protocol, but the glycerin gel
I'll let you answer that. I'll let you answer that.
Yeah, so obviously the glycerin gel is used in a number of different techniques for direct composites, and you will polymerize all the resin, including the oxygen inhibited layer. Whether or not that will be of any clinical significance in this particular technique, we don't know for sure, because there is no studies that have assessed exactly that variable. But I think it's a technique that if you use it for your direct resins, there's no reason why you should not use it for this particular technique as well. As far as sandblasting, it's important to recognize that, as Newton described during the lecture, sandblasting of the intaglio surface of the restoration of the resin is the protocol we recommend to favor adhesion between the luting medium and the resin itself. Studies show that sandblasting of the dentin, especially if you have highly sclerotic dentin, which usually is the case in a class 5 type defect, that procedure is helpful as well. But obviously for the veneers, for the contact lenses, especially if you're dealing mostly with enamel, that would not be recommended in those particular substrates. Newton, there are a couple of questions about U-veneer. You're familiar with Ultradent templates for veneers. I have a personal opinion about that. I'll let you share yours. I think they can, cut down some time if you want to use a template type approach or a matrix to generate the anatomy, but they are not nearly as customizable, if you will, as the technique that we describe in the book, which you just basically sculpt the anatomy. Essentially, if I understand correctly, I have never used this type of product, but they are a way to generate surface anatomy, particularly for direct approach. There's no reason why you can't use it for indirect, but again,
right,
there will be limitations.
Yeah. Now, veneers are interesting. Sigal Jacobson, who developed them, did a very nice job in coming up with average widths and heights. And you're limited to the morphology of the veneers, but if you find it's case dependent, if you have the right case with the right width and height, then it's easier for you to work around. Now, I have done the direct indirect approach with veneers, and if you want, you can all go online and look it up. You can follow veneer, and you see a case that I did on the lateral using the veneer just to get the imprint and flake it off and finish it outside mouth and then just bond it in. So you can use it too. But like Andre said, you lose the ability of customize the shape and the margins to the extent that you can with a direct indirect approach when you're doing the layering. But it's another alternative. Yeah.
There's a couple more questions about rubber dam, and I think I try to answer those questions, but it will be nice to get your take on it as well. So obviously, rubber dam for the direct indirect technique, the only reason you would use it is if you can't control the moisture, given that that's the main reason you use a rubber dam in a direct technique. But I think, as Newton pointed out, the bonding step or the intraoral steps for the direct indirect technique are minimized. And that's one of the advantages of the indirect technique. And rubber dam will be justified for the bonding step, which is very, very brief. And there are other ways to achieve isolation effectively. The other disadvantage is that rubber dam then will dehydrate the teeth, and then you lose the ability to fine tune your shade during try-in steps. So I think I wouldn't say, unless you just use it for the bonding, which Newton can correct me if I'm wrong, but it's just a couple of minutes when you're ready to bond the restoration. I don't think it will be paramount to use rubber dam in this technique. In fact, I think there are some reasons not to use it.
Yeah, it's actually one of the benefits of the technique. It's not having to go through the nuisance of putting a rubber dam on. It's at least from the standpoint of being a little, stressful to some patients who are claustrophobic, and the dehydration aspect that Andre brought up is very important, especially if you're doing your shade check and your try-in stage. So.
I think that's good. And then one last question, I think that we can discuss. Do you always silane the indirect composite restorations? And if yes, why? Wendy is asking that question. So again, one of the I would say a minor disadvantage of bonding indirect resins is that unlike porcelain that you can etch with hydrofluoric acid, indirect resins are not etchable in that same way. And one of the ways to maximize adhesion to that substrate, in addition to sandblasting that surface, is to silanating the surface so that you can enhance the adhesion potential from your resin luting cement to the intaglio surface of your restoration. So that's why we recommend using the silane. And that's very well described in the book, I think.
Yeah.
In fact, a lot of the questions, I think, as I went through them and I was answering them, I think we covered all of that in the book. Obviously, there's only so much we can do in an hour. There you go.
Get the book. Get the book.
Right.
Get the book.
And I think Leah is doing a good job with posting the links and information that people are asking about,
right.
Where to find it. I think this was wonderful. I wanted to, just in closing, and then maybe Newton can wrap it up, thank everybody for the participation. It's been a wonderful experience on a personal level to be part of this project with Newton. I've been following Newton's work for a number of years, way too long. I won't mention because it would date us. And I was thrilled when we had this connection last year. We visited on a couple of occasions when he was here in sabbatical. And it has been a wonderful opportunity and a big honor, Newton, really to be part of this project. So I wanted to thank you publicly for that. And thank you all for joining us today. It was a great webinar, a great session. Thank you also to all of the Quintessence team, not only for their help and their work during the production of the book, but also for putting this together, especially Christian out of Germany. I know it's a little late there for you, Christian. Hopefully you're still awake, but I wanted to just say thank you, everybody, and I hope you all have a great evening. Newton, I'll let you wrap it up.
Thank you, Andre. Thank you so much. Again, I can't thank Andre enough for having joined the project. This book, it is what it is on account of he being part of the team. And there's more to come. Keep an eye on it. Christian, thank you so very much for allowing us to do this. And I want to take the time here to thank everyone, every single one of you who have been sitting in front of your computer, your mobile, listening to us. I hope this has been of some worth to you. And in closing, I want to thank the Quintessence Chicago crew, everybody there. Bill Hartman, Bryn, Leah, thank you for putting up with all the emails back and forth, all the questions that we had. You guys worked so hard, but so hard to, you gave your utmost, your best to make this work of high quality, and it is what it is. Thank you so very much for helping us make this dream come true. Thank you so much.
Thanks, everybody. Have a great evening.
Thank you, guys. Thank you. Bye-bye.